Knee replacement is essentially an operation that is for end-stage arthritis or wear and tear of the knee, where the damaged cartilage and bones, where the cartilage is worn off and the bone is rubbing against each other, causing severe pain, deformity. Now we basically remove the diseased bone, and we introduce an implant which is made of basically different types of metal, cobalt chrome alloy, titanium, and there is usually a highly cross-linked polyethylene liner that is sandwiched between the metal surfaces. So it's an artificial joint that is used to replace severely diseased bone. Knee replacement by itself is not a one-size-fits-all approach that fits everybody. For example, what I'm trying to say is a knee replacement for an 80-year-old lady is different from a knee replacement for a 55-year-old, someone who's been an ex-athlete, has burnt out his knees by running, doing triathlons and things like that, and is still very active. These are two very different operations. Knee replacement is becoming more and more customized and individualized to the needs of the individual. We are seeing a lot of young arthritic patients, like that example I gave, who are still in the prime of their life, very active and have been very active sports people, and still want to be active and want to push the boundaries of knee replacement. So a lot of misconceptions are there. For example, what you can and cannot do after knee replacement. You can't sort of jump on the knee, you can't do a very deep squat, but besides these, a lot of activities can be discussed, and it's good if the surgeon knows in advance the needs of the patient, because knee replacement is becoming more of a customized solution to fit the patient's needs. Traditionally, our training has always been that there's a certain age, we must wait until that age, until we get before that we should never do a knee replacement. Now we're moving away from that concept. We are looking more at the physiological age of the patient and the knee rather than the chronological age of the patient. So using that example again, a 55-year-old athlete, triathlete who has end-stage arthritis and is having difficulties in terms of his quality of life, moving around, and he has bone-on-bone arthritis, is a candidate for knee replacement. So is an 80-year-old lady who has end-stage arthritis, but the considerations are very different. So in summary, there is no real age barrier. Partial knee replacement is a very good operation provided patient selection is proper. What do I mean by that? If the patient has isolated wear and tear in one compartment and has an activity profile that is suitable for partial knee replacement, then it's a good operation. However, one must understand that wear and tear in other compartments will continue, and the patient should be counseled appropriately that if that were to happen, there would be a chance that the partial knee replacement may need to be converted to a total knee replacement at some point. The subsequent operation of conversion to a total knee replacement is actually a more complex operation than if a total knee replacement were to be done from the word go. Prehabilitation is a very important concept that is coming up in terms of joint replacement surgery, sports surgery, sports medicine. Basically, the use of targeted physiotherapy even before the surgery, so that muscles are optimized so as to not have such an uphill climb after surgery for the individual or the patient. This is especially so in the case of the younger arthritic patient who has been a sports person in his or her younger days and is faced with the problem of arthritis at a relatively young age. A yoga practitioner who wants to sit cross-legged after surgery, is it an impossible task? No, it's not an impossible task, but we have to discuss. We'll have to make certain modifications to the surgical technique, and there's a plan. The rehab plan after surgery is also individualized to meet the needs of the patient. an avid cyclist who wants to cycle 100 kilometers after surgery every week, is it impossible? Of course, we would discourage it, but not impossible. I have one such patient myself who does that. But again, knowing what the patient is going to do to that knee replacement after surgery helps, because we can incorporate certain techniques during the surgery, certain rehab techniques before and after the surgery that would help the patient to do what he or she wants to do, and at the same time sort of minimize the adverse effects of wear and tear on the joint. We have moved away from the concept of bed rest, and we encourage very early mobilization after surgery, and this is only possible with adequate pain management. So surgically, the techniques we use, including the use of robotic assisted surgery, which minimizes muscle trauma and reduces the cuts that are, the type of cuts that we need on the bone. For example, we do not need to use intramedullary instrumentation in the bone when we use robots. So techniques during surgery, in other words, without getting too technical, that minimize tissue trauma. Robotic surgery is not a fashionable, fancy statement or a tool. It is basically a tool or a way in which we can individualize surgery to meet the patient's needs. So if we know it starts with a conversation with the patient, knowing what the patient needs, what the patient expects. We do a CT scan of the patient's knee or hip, before surgery. That's fed into the robotic software, and we have an individualized plan that we have for the patient in terms of surgery. We show the patient the plan, we discuss the plan with the patient, we execute the plan during the surgery, where the robot basically will make us cut within that very narrow margin. One of the biggest fears I have is that the younger generation of surgeons that I see training in various parts of the world are being trained on robotic methods, and if the traditional methods are not, if someone is not well versed in the traditional methods, machines are machines, and if machines have a technical issue, or if they fail, one must be able to bail out with traditional methods. We must be very well trained in traditional surgery, conventional surgery, because as much as we like robotics and as much as we want to advance robotics, we can't depend completely on robotics.